And it is July 9th, 2025. My name is Jens Chapman, and welcome to this edition of An Evening with a Spine Surgeon, co-hosted by our friends at the Texas Back Institute, Drs. Jack Ziegler and Scott Blumenthal, and also featuring Dr. Rod Askuin, my esteemed partner. Tonight's guest of honor is a surgeon who needs no introduction. He's one of our absolute leaders in the field. Dr. Christopher Shaffrey is with us, and he is such a unique leader and epigon in our field that we thought this would be just great to get to know him a little bit better on a personal level and not just in meetings. So tonight's guest of honor is Dr. Christopher Ignatius Shaffrey, professor, neurosurgeon, orthopedic surgeon, spine surgeon extraordinaire. And just going through the basics briefly, this could cover the whole hour, but his CV is unique. He graduated from the Citadel. He attended UVA, and Dr. John Jaynes Sr., we can talk about mentorship maybe, played probably a significant role. He did a unique thing. He managed to do 2 residencies in neurological and orthopedic surgery and did a UVA fellowship in spine surgery. Again, UVA is just one of those amazing institutions, and he's, I think, the only person that I know of at least who's dual boarded in neurological and orthopedic surgery. He served with great distinction in the US Navy, and then went to Henry Ford in Detroit, was an immediate presence in terms of trauma surgery and doing some serious work, then became a national figure very rapidly. I had the enormous privilege of getting to work next to Dr. Shaffrey at the University of Washington. Then he returned back to UVA as an attending, became professor. And since 2018, he's doing something particularly unique. He is the chairman of the, and we'll talk about how that's exactly called, the Department or Division of Spine Surgery. This is a visionary enterprise that Duke is doing. In academics, again, I'll keep this brief. This is an amazing work product. He has multiple grants. He is closing in on 1,000 scientific articles. He has over 300 book chapters. He's editor of multiple leading journals and editor-in-chief and section editor. It's an amazing distinction. His contributions to not only education, but also leadership and mentorship is incomprehensible. I don't know how he does that, but he's been president of CSRS, SRS, AANS, ABNS, Joint Section, IMAST, ISSG, and vice president of Neurosurgery Residence Review Committees. He's had multiple decorations I'm not going to list here. You see a little excerpt here, and he's always available to help teach, and he's influenced all of us, myself, gratefully included. And again, one of the key questions we can bring up later tonight, and there's nobody more qualified than him to talk about that, is should spine become its own specialty and finally get out of the shadows of its neurosurgical and orthopedic times. How decorated is Dr. Shaffrey? He is the immediate past recipient of the Harvey Cushing Medal. This is an extremely distinct, a very small group of people who are all game changers. If you look through the listing, and it's amazing to have a spine surgeon be recognized in such a fashion, and congratulations to you for this well-earned distinction. In terms of background, again, I'm not going to go into great detail, but one of the things that struck me was this enormous family unit that created these 3 great, highly productive sons with Mark, with Tim, and Chris. You see the proud parents as Chris is going through his maturation process. And again, he served in our Navy with distinction. He's still regarded with great reverence for his contributions there. I will add a sad note here, and we can go into that later. Loss is a big deal. Mark Shaffrey, the chairman of the Department of Neurosurgery at UVA, passed away very surprisingly December 4th, shockingly for all of us who knew him and adored him. And again, Chris and Mark were 2 of those absolute neurosurgical leaders. And if you want to make a contribution to AANS and NREF in memory of Mark, please do so. Chris is an amazing family man also, and his wife, Kathy, is depicted there. Intentionally did not depict the 4 children, but they're all very successful, and they've all really made him and Kathy proud. And this is a really cool, another aspect to talk about. How do you do all this? How do you accomplish all of this? How do you teach the thousands of people and influence so many people and are such a well-balanced family person? So Chris is a true standout. This is his Department of Spine Surgery. And the question that we'll lead off to, and I'll pass off to Jack in a second, is how did you do it all? How did you get there? And as Chris in our preparation for this evening mentioned, there's so much more to do, and he is right, and he is surrounded by really good friends of so many years. So it's an evening with peers and getting to know the private side of this outstanding leader. Thanks for being here, Chris. And Jack, I'll pass off to you.
Jens, thank you. That was a great introduction. Chris, thank you very much for joining us. And just want to pick your brain a little bit and find out how it's humanly possible to do all this stuff. Do you sleep, or you multitasking, or how do you manage to apportion your time between your professional life, personal life, and still enjoy life?
Well, so part of it is, I think all of us have to have kind of a North Star which we're driven towards. And for me, I was in a belief in a kind of a unique place of training where most spine procedures were done by a combination of an orthopedic attending and a neurosurgery attending. And it was good for collaboration, but whenever there was something that went wrong, each attending pointed at the other, this is a neurosurgery problem, this is an orthopedic problem. And what's happening is the principal orthopedic influences their number one priority was arthroplasty, lower extremity arthroplasty, and John Jane, who Jens mentioned, his principal focus was things like craniocervical operations, head trauma, and everything else. Now, for both departments, and that may influence our discussion about, what's preventing a unified effort. But for both departments, spine was a money maker for them, and because of that, that was something that prioritized engagement, but maybe not academic passion. So as a medical student, kind of rotated through both services, both orthopedics and neurosurgery, I saw at that time, maybe a bit naively, that there really wasn't a real passion for spine. And I said, boy, this is a huge opportunity to potentially make things better. And it was just sort of at the beginning of, Steffi doing some pedicle screw instrumentation, Kaneda doing a little bit of anterior stuff for trauma, the very beginnings of CD for deformity, but everything was in its nascency. And really, it was before many of the things that are current techniques that were available. So it wasn't a priority academically. It wasn't a real focus for many of the people that I knew as far as development or other activities. And at that time, nobody really knew whatsoever what the true outcomes were for non-operative management, for different types of surgical treatment. And because of that, I felt that there was an enormous opportunity to be able to have some influence over something which I thought was a enormously underappreciated and underengaged specialty. So that's kind of led me to be where I started.
Chris, was it a formal program to train in both, or did you design that and kind of wing it as you went along?
So I, as a third year medical student, wrote away to the American Board of Neurological Surgery and the American Board of Orthopedic Surgery. And I said, look I would like to do this. And even to today, about half of your training time in neurosurgery and orthopedics is elective. So I put together, kind of a spreadsheet, and I said, I'd like to do, this and this. And by what I calculated, you could do both of them, pretty easily within 7 years. And all of my elective time for orthopedics was going to be in neurosurgery. All my elective time in neurosurgery is going to be in orthopedics. I actually gave myself sort of a 6 month leeway and submitted that. And sort of the letter back from neurosurgery was amusing because it said, if you're stupid enough to do something like this. We'll give you the rope to hang yourself to do it. And that's kind of how it was. So I got a letter from both boards who said, yes, you can do this. And I talked to John Jane, who was the chairman of neurosurgery, and I talked to Warren Stamp and Guo Wang, who were the chair and kind of vice chair, co-chair in orthopedics, and they said, sure. So I put that together, and then the match wasn't quite as regimented as it is now. So I was able to, to say, kind of outside the match, I want to do this. So neurosurgery had two positions. One was in the match, one was in the outside. Orthopedics had six positions. Four were in the match and two were outside of the match. And so I was able to get an outside the match position for those activities. So I did do that during my third year. I got accepted. They kind of accepted me going into the fourth year, and I just followed along with that. And the only thing that complicated things a little bit was I had originally agreed or discussed doing a spine fellowship after I completed this is maybe a couple years later with Henry Bowman to join his group and as a fellow, and Don Chan, who was kind of recruited in orthopedics from Rochester to come to UVA, somehow had heard that about me and said I want him to be my fellow next year. And I was kind of pressured to call Dr. Bowman and tell him that I was going to respectfully back out of what I had committed to doing, which was a little probably the most uncomfortable aspect during this entire process. And then Don Chan called him and said, "Look, we're putting a lot of pressure on him to do this. This wasn't totally of his own volition." So that's probably the only complexity that I had. But I did both residencies and a fellowship, and I guess I did all of that in 7 years. So it was a little bit different right now, and now so many like the Seattle Foundation and your all's fellowship, Jack and Scott at TBI, it's a different world. Back, again, 30 years ago, what you did in neurosurgery, what you did in orthopedics was very siloed. And over the past 30 years, this is all kind of melded together. And I think the pathway of doing fellowships is a different world. I think it is another very successful way to do it. Now, what had happened was that in neurosurgery, there was a belief that anything involving particularly spinal instrumentation, deformity, spondylolisthesis, any of those things, that there was a belief that that was something that neurosurgery should let go. They said that's not an inherent part of neurosurgery. And I would say, where my career has had some benefit is that probably about half of neurosurgery said, look, we don't want to let spine go, that there's some real disadvantages to letting that pass on. And so I sort of rode the wave of the belief that spine should be part of neurosurgery. And that allowed me to do some of the other things which Yen so kindly listed.
I mean, what's even more remarkable, Chris, is that now neurosurgery and orthopedics are fairly collegial when it comes to spine, but it wasn't like that 30 to 40 years ago. Neurosurgery and orthopedics usually were button heads. And the fact that you were able to merge, convince both boards to allow you to do the training is really remarkable. And as one of Henry Bowman's early fellows, I'm sure he got over it. So
Yeah,
he'd be proud of you.
and so I think what's happening was that was something that was fairly unique about UVA, and Rod knows this so well, was it was a pretty collaborative atmosphere. And the expression when when the rats have enough cheese, there's no fighting. There was so much spine going on at UVA at that time that there was no real competition. So what happened was, and again, for the 15 years before, most of these cases were done in a co-surgery manner, where John Jane would go with, Guo Wong or Warren Stamp or Dick Whitehill and do these cases together. So there was a history of collaboration. Now, as Rob was kind of at the tail end, but he remembers whenever there was a complication or an unhappy patient, it was never the parents or, oh, that's because the fusion didn't take or the screws were loose or misplaced, or, oh, the decompression wasn't adequate. So there was a bit of friction, but the overall atmosphere was a collaborative one.
Hey,
So
Chris, let me.
I'm gonna.
Oh, sorry.
Oh, sorry.
You go first, Scott.
No. So I was going to ask number one a silly question and then a comment. Um, Having done both orthopedics and neurosurgery, with obviously the commonality being spine, when you weren't doing spine, what was more interesting to you, doing heads or fixing hips and knees?
Well, there's nothing more depressing than having a severe head injury that you're dealing with, or a malignant brain tumor or something like that. Most of your trauma patients are actually an amazingly happy and grateful group of patients. You have a tib fib fracture, or you have an old lady with a intertroch fracture. Those are actually very happy. And so a little of my, kind of passion is I love a good looking x-ray. So to try to go and to do something, an MRI scan, you take out two-thirds of a primary brain tumor, and the x-rays still look like crap after you finish. But you do a really slick, femur fracture, and the x-rays in my mind look pretty good. Okay. And so for me, I probably enjoyed my orthopedic time more. But I'm going to tell you, and this is something that I think that, residents and fellows struggle with, is that, that as far as, the consequences of a poorly conceived or poorly executed surgery are far greater in neurosurgery. If you're going to go and you're going to clip an ACOM aneurysm, and you clip, the parent blood vessel or one of the vessels there, you have absolutely devastated that patient. And it's an instantaneous devastation that you don't see for somebody that's, externally rotated 15 degrees after a femoral rod. So what's happening is neurosurgery, I think, and this has kind of led to my passion for outcomes-based research. And, Jens mentioned the sort of the publications I've had, but that was a matter of, process improvement. And my involvement in different study groups and everything was, how can we do this better? What are the things that we can overcome to reduce complications, to get better outcomes and whatnot. And most of that, at least in my experience, was more related to neurosurgery, because that was so important, because the complications of having a bad outcome were absolutely devastating. So the ability to say, look, if I do something wrong or if I do something bad, is brought home in neurosurgery. As far as the things that I enjoy, a great looking X-ray or something, when I see somebody walk up the hall who is functionally, enormously benefited, that is an orthopedic thing. And I think that, some of the work that's just has been reported in JAMA regarding the 8-year outcomes of the adult symptomatic scoliosis trial, which I was involved in, the results of that are as good and maybe better than anything else in medicine. We are doing stuff as spine surgeons that's better than our arthroplasty colleagues. It's better than our pulmonologists. It's better than our people who are doing cardiac transplants. It's better than our diabetes doctors. What we are doing as spine surgeons is the best, interventions in medicine. And I think that's, I don't think we tout our horn. We took a pummeling back, 20 years ago when, there were, 50% improvement for surgery for, discogenic lower back pain. And maybe or maybe not, that was the right thing to do. I do think that most people who are in desperate pain, that 50% is something that is noticeable. And all the studies showed that. But for my passion and Jens's passion and Rod's passion to a degree, when you look at the outcomes of complex deformity, it's number one, the most single debilitating condition in medicine. And number two, it's a single delta for improvement of anything that's been done. And as I said, I don't think that we have done enough to bring to attention that we are doing the best interventions of any intervention in medicine.
Yeah, well said. And I want to get back to what Jens teased earlier. And I know Jack and I have talked about this, and I'm sure Rod and Jens have talked about as well. In our fellowship, obviously we train both orthopedic and neurosurgeons, and the backgrounds are enough different that there's a noticeable delta. In other words, if a patient's not doing well, has a progressive lower extremity deficit, our neurosurgery fellow will be the first to add Guillain-Barré to the differential. If someone's doing poorly from a C5 radiculopathy, or ortho fellows will be, it may be a shoulder issue. Let me look into this. So what I kind of want to get back to is what Jens teased earlier, is your feelings on the concept of a spine specialty, standalone in and of itself. And Jens, feel free to jump in, or Rod or Jack as well. But I really would love to hear, because you've got such a unique perspective, having trained totally in both.
Well, so I give a talk, and I see my daughter and grandson just popped on. I give a talk, and I say how integrated programs are the future of medicine. And there's a lot of reasons why that is: a duration of training, this, that, and the other thing. But what's happening is, in plastic surgery, the first integrated plastic surgery program started in 1960 by a guy out of Stanford. And he just said, spending 5 years as a general surgeon or 6 years as an orthopedic surgeon and going into plastic surgery is a waste of 3 or 4 or 5 years. So what happened with that is the American Board of Plastic Surgery would not accept integrated fellows for the American Board of Plastic Surgery, and they had to form their own board, the Board of Integrated Plastic Surgery. And so the problem is that if you look at most departments, and in TBI is a bit different, but if you look at in there, maybe if we talk to Frank, or we talk to Steve Lockey, most programs depend upon the revenue from spine surgery to drive their programs to make it profitable. And what happens is, even though it may be the best idea, right now there are enormous headwinds. And I was, the chair of the ABNS, and I was the vice chair of the Neurosurgery Residency Review Committee. And I'm just going to tell you, there are enormous institutional headwinds against spine splitting off as its own division, even though it makes absolute total sense. Now, part of the talk that I give is general surgery, who adamantly refused to allow, infolded fellowships and whatnot. And they are, being a psychiatry resident is more competitive now than being a general surgeon. And so what's going to happen is eventually it may be driven. But in many places, and again, it would be interesting for those, at UVA or other places, but we have people showing up for fellowship after orthopedic training who have done less than 15 total spine cases during the course of their residency. And the average neurosurgeon who is planning on going to a spine career will do 1,500 cases, and 1,200 of those will be as the primary surgeon. So even though there's a feeling that many people can catch up, that's not always the case. So I'd be interested, Jens and Scott and Jack, what is your experience? Because what I'm saying is, particularly after COVID, you're having people that are coming into fellowship that are really disadvantaged going in from experiential perspective.
Let me take that first, and then I want to pivot to Rod there. So this is a really poignant thing, because I always thought that ortho and neurosurgery residents had equal footing, and I've changed my mind. I get to work with great neurosurgeons at the Seattle Science Foundation and Swedish Neuroscience Institute, and I do think that as a whole, the neurosurgery residents that come to us now are way better trained. They're way ahead of ortho surgeons. And this is, again, a mix of work hour restrictions, a lack of exposure, formal exposure to spine. I've seen that with some concern. Rod, what are your thoughts? We have even ortho neurosurgery fellows. So,
I mean, I think as neurosurgery residents, we just get, from day one, you're exposing, the lumbar spine, posterior cervical spine. To me, what's always impressive, Jens, is how quickly, the orthopedic fellows catch up to the neurosurgeons. And I think they have different skill sets. I think the orthopedic surgeons are very good with instruments, because you guys are doing all that from day one, whether it's hips or fractures. So I do think they come a little bit behind, but I think it's just because in ortho, there's so much to learn. Whereas in neurosurgery, you're either doing spine or cranial. And I do agree with you guys. I mean, it's interesting I do think there is some, obviously, most ortho departments and neuro departments, it's like spine is always I would say, the kind of one of the main backbones, but they also don't, like the cranial surgeons kind of poo-poo spine. And I know the joint surgeons kind of do the same thing. And so I do think it makes sense. But I think from a financial standpoint, I do agree with Chris. I'm not sure if the societies and the departments and, the way things are structured right now, that a lot of places will let go of spine.
Do you think navigation is the great equalizer?
I
Well,
think robotics, I think robotics and navigation are definitely going to help.
So I guess, Scott, that's the question, is that, if everything goes okay, there's not the equivalent of a bird strike or the engine going out or the hydraulics screwing up, you're probably right that you can do it. But suddenly, and including at Duke, we've had cases where the integration for robotics has that they've gotten essentially the equivalent of the blue screen of death. And we have junior faculty who say, that's it. It was an L4-5 isthmic spondylolisthesis, and they said, I'm not comfortable proceeding. And I had somebody, because it was a more acute case, that had an odontoid fracture with a neurological injury, and one of our junior faculty, that somehow the 3D navigation and the et cetera didn't work. And so she said to me, look, I'm going to cancel this case. And I said, you got a fluoro there, right? And I said, let me see the CT scan. I said, there, you got very favorable screw paths, to put things into C1 and C2, and it was said, I've never once ever put a screw in residency or fellowship without navigation. And I am completely uncomfortable doing that. And I said to the OR, put this case, my responsibility, my thing. And so I'm putting the screws in, I'm putting, C2 par screws in. And she goes, I measured those at 14. And I said, look, and I've looked at it and I'm putting, 4026s into C2, and this is what I'm doing for C1. And she goes, oh my God, oh my God, no, you can't do that. And I said, yeah, I can do it. It's my responsibility. I'm going to do that. But that is the difference, when you say, hey, look, that's going to be the great equalizer. It may be an equalizer if everything goes okay. But the other thing is, and maybe this is for you, Scott, and you, Jack, our residents, some of them don't know that we're getting pre-manufactured rods. And they say, well, how do you know how to bend a rod? And I said, well, you look down there and you see, and I look at the x-ray and I've measured it out beforehand. They said, I've never put a rod in that hasn't been bent by the company beforehand. And as we talk about, economic and social responsibility, when everything is a robotically placed screw and a pre-manufactured rod and a pre-manufactured interbody implant, is that something that is financially beneficial? And probably you guys are, way further on the cutting edge. So Scott and Jack, I'd be interested to hear what you guys say about that.
Well, it's interesting. We poll the fellows at the end of each year, and two of our attendings each do mission trips to Africa, one to Uganda, one to Ethiopia. And invariably, we ask what their best part of the fellowship is. It's when they go there and have to do everything freehand. And I totally agree that that needs to be part of training. When the equipment goes out, can you still do the case? I mean, what do you think, Jack?
Yeah, no, I think there's a loss of the old guy skills, of being able to palpate things and be comfortable that you're in the right entry point. Um, uh, and that's the nightmare, is that you're so reliant on your instruments that when they go out, the pilot can't fly the plane anymore. So that's one of the issues with advancing technology, is that the younger surgeons get more and more dependent on it. It's like in the old days when we were training and taking iliac crest bone graft, and you would take as much as you could, and the attending would pick up the instruments, and he'd still find a lot more bone that you had missed. There's a learning curve to an experiential, but it was hands-on. And I think that one of the fears is that the younger guys are going to lose out on some of that. So I would agree with you.
Let me just say one. I have a great story about Chris and Jens, and I'll give you. And I think this will give you guys an idea of what I think a lot of what we're talking about. So I was a medical student at UCLA, and I remember I did a rotation. I did a rotation at Virginia, and John Jane said to me, look, Rod, I know you're really interested in spine surgery. Why don't you go to Seattle and work with Dick Wynn? And there's two guys there. One of my guys is there, is Chris Shaffrey. And there's another surgeon named Jens Chapman. And he said, if you really want to learn spine surgery, you got to go spend a month in Seattle. And I remember going there, and they had probably one of the busiest services, and it was a combined rotation or fellowship / infolded, and basically Jens and Chris ran, and it was like a combined service. I mean, I think that's really what, regardless of whether there's whether we have a true spine, training. I mean, this was the most important thing I think that happened in my career, working with, just seeing how Jens and Chris were with the residents, the fellows, neurosurgery, orthopedics, and they both brought really valuable insight, into cases. I remember there was some bad, traumas that would come in, and Chris and Jens would be kind of talking about, do this, do we do that? What's, what kind of, what's the procedure that we're going to do? I think that's the real value. And honestly, having spent that month there and working with Chris and Jens really had a huge impact on my career.
That's kind to say. And I add to that, it is common in spine to disagree about things. Just join us next Tuesday in our disc arthroplasty forum. And we always disagree about everything in spine. It's notorious. But the crazy thing was the fellows and the residents were actually playing us, because they would ask Chris and me when we were not together in the same room, what would we do? And the literally nutty thing was, without us knowing what the other one would say, we literally agreed in like 80-90% of cases, right, Chris? I mean, it was just like we had the same thought processes of what's the priority and how to approach it. And that's a rarity in spine. I fondly remember having this big guy there, and the quality and just the thoughtfulness and the resilience and the tirelessness of his work was just amazing. Let me pivot a little bit on the tiredness and a fatigue factor of work to the richness of life. And that's, again, the family angle. By the way, if we can pan out or come over here, we have a special long-term bond of ours sitting right here. Tanya Nguyen, and she wanted to say hi.
Hi, Chris. How are you?
Hey, Tanya. Good to see you. So a couple things. Number one of my female colleagues said, "Oh, I hope you're not talking about me, about the one who doesn't know how to do the fluoro." It was not the person that texted me. But it's not a matter, it's a matter of, and everybody should do what is right for them to do. But inevitably with technology, there is always an opportunity for it to go to crap. And what I would say is, not that technology may not be the right thing. And I think as we move forward to some new things in the horizon, like cervical pedicle screws and other different things, that it may result in better outcomes. But ultimately, there's going to be a situation, and I'm going to tell you, if you were in an airplane and someone said, if the flight computer went out, this plane is going to crash because my pilot doesn't know how to land the plane on his own, none of us would be happy with that. So what I'm saying is, we probably could refine what we do and do it better with technology. But I wanted to make the point that we also need to have backup plan B and C. And so one of the things which, that I always enjoyed and respected with Jens is, he is and was just an absolute master technician. And, and yes, Jens might say, or I might say, or somebody else might say, look, I can do this 2% better by doing this. And there's some reasons, this, again, part of the text that I got was, I think there's a reason for pre-manufactured rod, probably less rod fractures, less rod, notch sensitivity. You can make a case for it. But I also have to tell you that there's a trauma case in the middle of the night where you have to bend your rod, and if you have a craniocervical dissociation, you need to be able to hook that up and do that as a backup plan with that. So I don't want to be overly negative, but when someone says, "Hey, I'm trying to do craniocervical dissociation," which I can't do because I can't call my manufacturer of choice to make me have a rod that I can bend in the appropriate configuration, we're not training people appropriately.
Well said. By the way, I put your article on the long-term outcomes and JAMA into the chat room, and I see the hand raised by someone named Steve Schwartz. Steve from Philly, who wanted to say hi. You got to unmute yourself, Steve.
Yeah, Steve, unmute.
Okay. I'm not good at lip syncing, so got to hit the unmute and take the hand down.
There we go, Steve. Go ahead.
Hello, how are you guys and women? Listen, Chris, would you do me a favor, if it's okay with the meeting organizers, and talk a little bit about your relationship with John Jane? I found it really fantastic to watch the two of you in action, two legends, and John clearly thought the world of you, how he critiqued your work, how he improved you, how he mentored you, and whatever else you can share that was quite unique and special for the relationship of you two.
So, what's happening was that I've told the story that when I was a third year medical student, you chose your selection for what rotations that you wanted to do. And basically, there were like 14 surgical subspecialties: pediatric surgery, transplant surgery, colorectal, trauma surgery, et cetera, et cetera, et cetera. Orthopedics, urology, ENT, plastic surgery. So basically, the rotation comes out, and basically, my two elective selections were orthopedics and neurosurgery. So I went to the rotation coordinator and I said, "Look, if there's got to be some kind of mistake, I put neurosurgery down as 12th of 14." And the residency coordinator said, "You're the only person in your med school class that didn't put it 14th." And so they said, you selected it automatically. And at that time, the residents were Dennis Vollmer, Sean Grady, Ralph Dacey, people that have just been icons of neurosurgery. But the one who led the charge was John Jane. And John had an enormous amount of foresight and an enormous amount of flexibility that was beyond the traditional neurosurgeon's thinking. And part of that was there was a guy named Milt Edgerton who was a plastic surgeon, and they had revolutionized the treatment of babies with craniosynostosis. And to do that, there was some real out of the box thinking that occurred. And so what happened was he had a degree of flexibility that it was very open. There was a guy named John Persing, and John did a plastic surgery fellowship after neurosurgery and was very, very big in the world of craniofacial. And so he thought this kind of cross training was something that was very beneficial and wasn't something that could be done. So John was somebody who really thought out of the box. And we had within the neurosurgery department some extraordinarily gifted surgeons, principally a guy named Ed Laws. And so what happened was there was this thing of, perfection and how, your individual actions as a surgeon profoundly influenced the outcomes of surgery, which was something that was really, I think, somewhat revolutionary. Orthopedic surgery was strong at UVA, particularly our arthroplasty group. But they, how somebody did was, maybe, it was not the thing of looking at outcomes. And Rod can probably tell you about this a little bit. But Ed Laws, if he was going to do a pituitary surgery, you would know within a few days whether he was successful by what the hormone levels were after it. There was no hiding from the outcomes. And I was taught that there's no hiding for the outcomes. And for me, when you're talking about, the things, I was involved with the ISSG, and I was involved in the spine deformity study group. And I was involved in the NIH, adult symptomatic lumbar scoliosis trial. We were all looking at things to do it. And as Jens remembers, 25 years ago, Scott and Jack will remember as well, they thought that the results of surgery were not sustainable. And the reason why the NIH funded it was their hope within 5 years to prove this was a terrible intervention and it wasn't worth doing. And the fact is, it's been exactly the opposite. It's shown that it's enormously beneficial. It's more cost effective than doing a microdiscectomy. And compared to non-operative treatment, it's enormously cost effective. And so all those things, were, I think, related to the out-of-box thinking of John Jane. John was somebody that didn't follow traditional conventions and wanted people to do things and think of things that were out of the box. And I think that's his greatest legacy, Steve.
A great question. Let me go back to a little bit further. And again, the enormous impact of Dr. John Jane on all of us, even in the West Coast in Seattle, cannot be overstated. I had the great pleasure of getting to meet him and know him. And I just admire him and his work. And this enormous biogenerator of greatness and UVA cannot be overstated. Going back to your family, so something was done right. I mean, your parents did something incredible. 3 leaders in their field. One sadly has departed, but what did they do and how have you, and this will segue to Scott in a second, what did you then apply to your own family as your kids went into career paths? So what happened in your family that set off this enormous nucleus of greatness?
Well, I will tell you that, there was 2 different, I think, components. Is number one, much like in my family and with my daughter's family, that the real smart ones in the family are the women in our family. And my mother was a very, very smart and talented person who kind of, gave, of herself to raise her children. My wife, Katie, is the same thing. That again, she was a Fulbright scholar. She taught German literature in Switzerland. She did all this stuff, and basically, even though she still continues to be involved in academic medicine, that she put her principal focus into raising our children, including our daughter Ellen there. And I saw our daughter had her son, and I think that the entire process may continue to repeat itself. My dad was an engineer and got married relatively younger after being in the Navy. And I think he was always a frustrated doctor. He always said, if I had to do it over again, I would have gone to medical school and done this instead of, being an engineer and in pursuing the career that he did. So I think that he instilled I think the benefits and the glory and whatnot, maybe, a little bit emphasized it, but basically that the highest calling of different career paths was to be in medicine and to make a difference. So I think my mother's intelligence and drive and my father's belief that there's no higher calling than being in medicine. So I kind of initially moved in that direction, and my brother Mark followed. He originally wanted to be a trauma surgeon, and then he went and had an Air Force commitment, and he went down to Wilford Hall, and he hated the trauma rotation, but loved the neurosurgery one. So I talked to Dr. Jane, and Dr. Jane, my brother was AOA and a lot of other things, and brought him in because we had a couple deficits in the program. And so, what's happening is that the same kind of situation kind of has repeated itself where, I've done, a bit what I've done, but the true driving force, the true person that has driven our children to success. And Ellen's youngest sister Izzy is a 3rd-year medical student at Duke. Her brother is finishing up business school at Georgetown, and her sister next younger it just is completing I think it's her 2nd PhD in England right now. And I think that this was mostly driven by the success and dedication of their mother, like my mother did similarly. So the answer is that, I think that like most of the people, and I certainly know with Scott that, that his influence has similarly passed a generation with his enormously talented daughter Zoe. And so, what's happening is that, that if it was me on my own, Ellen would probably be working at Chuck E. Cheese, mopping the floor. But due to my mother, and particularly her mother, that is changed to really enormous talent. And so I've been just lucky. My effort that I've had to put in has been relatively limited, and my success and I think our children's success has been much more related to the women in our family. And if you see Ellen with her son, that's continuing to move forward.
Scott?
Okay, so as you can see, Chris has already seen that Ellen's on the panelist, and Zoe Blumenthal as well. And I told them that I would not put either of them on the spot, but I do have one question for both of them. So unmute yourselves. First of all, Zoe Blumenthal, who's a urologist, all the prostatectomies in our hospital now are done robotically, navigation, etc. Do they even teach open prostatectomy anymore in urology residencies? And if the robot's down, do you just do the case another day? Quick, yes or no? You don't have to be put on the spot or anything.
I don't see Zoe on right now, Scott.
She was.
Can you
No,
text
Zoe?
her? Can you text her number to Hannah? Can we pivot?
Let's see.
Can we pivot to Ellen?
Oh, okay. All right. Well, Zoe's off. So, Ellen, number one, do you have any questions you want to ask your dad? And if you don't, I'll ask you a question.
I don't think anything that comes to mind, but this has been amazing to hear about sort of the collaboration between orthopedics and neurosurgery, and is really inspiring for me in plastic surgery in terms of how to work with my colleagues and how to maximize my success in the field.
Well, I know as a dad, when you go to medical school and you got to choose your specialty, it's very obvious whether you want to be a surgeon or a non-surgeon. And while I'm sure that he would have loved you to follow and go into neuro, ortho, or spine, just to see that you went into something surgical is very rewarding to me. I'm sure it's very rewarding to him. And so, congratulations. And again, keep it going generation to generation. And we look forward to having you in Dallas in a year as well.
I'm very excited. I did think about ortho, but Izzy, who's also on the call, is going to fill in that gap. She's pursuing orthopedic surgery, so spine's not totally lost on the family, maybe.
Well, we'll both be both Jens and myself will both be wanting her as a fellow after her orthopedic residency when she wants to go into spine. So we'll be competing for her services.
She's the smartest one out of all of us, so good choice.
So Ellen, I'm going to ask you a difficult question and then pivot to your dad. So of all the subspecialties, spine surgery is one of the worst in terms of female representation. It's still, I think the statistics are still pretty glaring, Chris. Both orthopedics and neurosurgery has made great strides forward. Spine is clearly lagging behind. As a female successful surgeon, I would have asked Zoe that same question. What is it about spine that would give you hesitancy outside of your dad, if you're not related to that Christopher I. Shaffrey?
I'd say that alone. I mean, I've seen the grit and dedication and passion it takes to be successful. And I think the training to be a great spine surgeon is something that you can't circumvent or shortcut. You really have to dedicate yourself to providing patients with the best outcome. And I think that's maybe what causes hesitancy in female residents, either neuro or orthopedics, who want to start a family. But, I think that the field is continuing to make strides. It just is going to take time. That being said, in order to be the best spine surgeon possible, like my dad is, I've clearly seen the dedication and time it takes to become that level of an expert.
Chris, nationally speaking, so you have obviously incredibly talented children, and we're blessed to have Ellen here. Thank you for taking the time, Ellen.
Of course.
What do you see nationally happening in terms of spine kind of catching up to the rest of specialties? Where now in medical school, over 50%, like UW has like almost 60% female medical students now. What do you see happening in spine to try to get a better gender balance going?
Well, I'm going to tell you, I think it takes great leaders. And and I will tell you that I feel that I am blessed at Duke, that we have Kristen Jones and Paris Fatimi, and Melissa Erickson and others that are here, that are part of our faculty. And I think that as people can navigate and show that you can do that and have work-life balance, and you can be really, really successful, I think it's going to make things better. The part of the problem, or maybe the difference is that Jens, I recognized when I was at University of Washington that you were perhaps one of the most talented surgeons I've ever worked with. It's technically unbelievable. And I think that, that one of the things which, and I'd love to hear for, I think Zoe just popped back on, and for others, um, you know, and maybe as I'm getting older, I beat myself up more for having a complication compared to what I was when I was younger. But when I was 40 years old and I was working with you, you know, I truly felt that if I was doing something and something bad happened, and is this going to be, probably blasphemous and disrespectful, but I thought to myself, that's God's will. There's nobody that's in better position to do better things. And if Jens Chapman has a complication, or if I have a complication, that's the way it goes. And I think that many of our female colleagues really take to heart, to a different degree, and maybe it's a thing of nurturing, it's maybe a thing of upgrading, that really that things bother them more than it used to bother me. Now, I'm telling you, that's changing as I age a little bit. But I think that's one of the things that's intimidating about going into spine surgery, that that we have lots of complications, right? We have complications every single day, and despite me having complications, I can still generally sleep at night. And I think there are people that really unnerves them to a degree. So I'd love to hear from our female colleagues, Zoe and Ellen. I see Izzy's on the call too. When she's looking to go into stuff, is that something that is inhibitory? Zoe, I know that your dad called you out before, so maybe you can answer that, then you can go back to your dad's question.
You have to unmute. While she's unmuting, I can second the fact that Jens and I were residents together, and absolutely the most talented surgeon I've ever worked with.
I learned from the best, and you were one of my attendings. So back at you, and Chris too.
Ellen, so why don't you comment while Zoe unmutes? Is that something that inhibits people? The fact is, if you're having something that normally has a 50% complication rate, is that something that inhibits people from going into it?
Sorry, I had to update my phone to unmute myself.
Zoe, you go ahead first.
No, I think Ellen was about to talk. She can talk and then I'll follow Ellen.
I don't know. I think it's all personality based. I know plenty of male residents that I work with that probably take complications harder than I do. So I'm not 100% sure gender alone is part of it, but maybe in spine. I don't know.
I would agree with Ellen on that. I think, urology being a pretty male dominated field, I'm one of the few female residents. I do think my male colleagues take it equally, if not harder than I do. I think I maybe have the Dr. Shaffrey mindset of, I don't know, for better or for worse, but if it's God's will, like, you're at the best place for this intervention. And I don't know if that's right or adaptive to kind of deal with what we're going through at the time. But that's kind of how I mentally kind of handle more difficult complications.
That being said, we were both raised by pretty steel-minded people, so we might be outliers in this question.
Hey, we're getting to time, but I want to just close maybe as we have two future leaders here with Ellen and Zoe. So cool for both of you to join us, and the great Dr. Shaffrey. So Dr. Wilma Godoy, we have visitors from around the world, and a great question by Dr. Godoy from Colombia was, looking back at the past 30 years, what's the big next thing for the next 30 years? Maybe we'll have Dr. Shaffrey looking back at his extremely successful 30 past years, give us a framework for the future, and then wishes and prognostications from our two young surgeons, Ellen and Zoe.
Well, from my perspective, I think it's two things in the short term. One is I think that kind of AI and learning who to operate on and who not to operate on, at least in adult deformity. If you take the bottom 15% as far as people with the worst outcomes, if you eliminate them and you figure out who not to operate on, the rest of the people do extraordinarily well. And I think the second thing is, I think there's going to be a real thing for biologics, that I do think that you want to stop the degenerative cascade before all these terrible, terrible things happen. So I've got a belief that things like disc regeneration and other different interventions, whether it's things like medical optimization and looking at ways from proteomics and whatnot to be able to go and intervene much earlier in the cascade to improve things. So I think they're kind of the two things that I would say over the next 15 years that are going to, drive what we're doing forward.
Ellen, do you want to take the microphone?
I kind of similar to my dad, but even sort of catching the problem or circumventing or preventing the problem before it even arrives, finding ways to prevent development of different diagnoses or diseases. It may ultimately lead to some surgeries becoming obsolete, but that's in a good way. So I think as the technology and sort of AI continue to develop and our research continues to expand, hopefully that'll be the way of the future.
So risk profiling, which obviously could be abused by insurance carriers. I'm not mentioning any specific companies that start with a U, but I could see that downside right off the bat. And Zoe, as a urologist.
Yeah, I think in urology, I think the future is really in immunotherapy and genetic sequencing of different cancers. I'm studying for my boards currently, and just when I look at where we are now versus even where we were 4 years ago, just our ability to target different gene therapies and immunotherapies is really changing the game in terms of urologic cancers. I think we're operating, people who we thought maybe had a 2-year survival are living 10, 20 years now based off immunotherapy. So I think that is kind of where I see the future of urology going, is definitely in immuno-targeted therapies for different cancers.
You guys have already been very successful because I think Chris and I see more renal cell cancer patients survive 10 years plus and putting whole new problems for us, right, Chris?
Yeah, yes, indeed. For you and I, the more people screw up, the better it makes it for us. But I think across as a specialty, doing the things that just Zoe and Ellen said is going to be enormously impactful moving forward. I think that the AI is going to sort of objectify things, and I'm probably not as worried about insurance. As I said, if we eliminated the bottom 10%, everything else that we do is going to be enormously successful, better than anything else in medicine. So I think we are uniquely positioned we eliminate the bottom 10% and let the insurance company be the bad guy to eliminate them. We'll take the 90% of the rest, and Scott and Jack and you and I and Rod will ride to the future on the wave of enormous success.
So we have to come to a close. Maybe closing words from Rod and Jack, but before that, Chris, I want to thank you for the inspiration that you provided for all of us, myself included. This has been an incredible ride and experience. And again, I feel energized again just having heard you talk. And we need to have a follow-up session just on residency one of these days, because clearly you have more thoughts behind this than anybody. But thank you for inspiration. Thank you for your enormous energy and devotion. Having somebody like you in a leadership position is incredibly valuable, because you're a real person and a very pragmatic person. So you know what's going on in the trenches. Rod, and then maybe Jack, who has always the big picture perspective.
Yeah, I mean, I'm super lucky, you know, that I got to meet Dr. Jane, and then he's the one that pushed me to go to Seattle to work with Chris. I mean, I was a med student, you know, what did I know as a med student? But he said, look, if you were really interested in spine, you got to go work with Jens and Chris. And thank God I did, because it's had a huge impact on my career and my profession. So it's really been an honor, and truly lucky to have Chris and Jens in my life and as mentors and colleagues now. So,
Yeah.
All right.
And Chris, I just want to, you know, when Jens and I brainstormed and then greenlit this series, really the goal was to spend a little time with someone who was otherwise iconic on paper, and discover the humanity. And I think this has been a great hour to see that, you know, there's a good guy with a good heart behind all the papers and the presentations, and you know, the generational aspect that Scott pitched in here with your daughters is pretty unique also. So, you know, we appreciate the time you spend with us, and give us a little bit more insight into Dr. Chris Shaffrey. So thank you very much.
Thank you, everybody. Have a wonderful evening.
You too. Everybody stay well.
Thanks, Dad.
Thank you.
Thanks, Ellen. Thanks, Zoe.
Thanks, everybody.
Next time, Izzy.
Thanks, Dr. Blumenthal.
Take care. Thank you.
And the grandchildren next time.
Yeah.
Take care.